1. This presentation focuses on care coordination, clinical services, and clinical therapy services. Sections 19, 20, 21, 40, 96, and 102. My name is Kristen Gore, and I'm a senior consultant at Public Consulting Group. I'm the project manager of this initiative. PCG is a public sector focused management consulting firm that assists public agencies in better serving their targeted populations, specifically human services, health, education, and technology consulting. In particular, many of our projects are focused on rate determinations, much like this work that we are presenting today, in collaboration with MaineCare. So let's get started. All right, so for today, our agenda is focused on first a welcome and some reminders. We'll do some brief introductions, and then we'll jump into the rate reform process and review. We'll discuss the draft rate setting methodology and model inputs. Then we'll walk through the draft rate recommendations, and then discuss next steps, a Q&A, and details for public comment. All right, I'll pass it off to you, Kristen.
Thanks, Kristen. Hi, everyone. Good morning. My name is Kristen Merrill. I am the Associate Director of Program Implementation within the Office of MaineCare Services. I just want to start off today by saying a big thank you to everyone for their time and their participation throughout this study, but also today in particular. We'll be diving into the MaineCare rate reform process and draft recommendations in just a few minutes. But before we do that, I just wanted to take a moment to touch briefly on a few different things. The first is that this was a very large effort and has taken a lot of time. And as many of you know, this effort overall touched on 9 different sections of policy within the MaineCare Benefits Manual and close to 130 different service codes. So these draft rates will be presented across 3 different presentations. First presentation was yesterday, we have today, and then we also have one on Monday as well. And so part of the goal of MaineCare rate reform is alignment across sections of policy, or to say that differently, it's an effort to create payment equity where the same or similar services are under different sections of the MaineCare Benefits Manual. And so this can result in draft rates that recommend increases or decreases across various sections. There will and has been consideration of state and federal requirements. So this includes things like 22 MRS 7402, which is the Essential Support Worker Reimbursement Statute. And so that requires that the wage component of rates are equal to at least 125% of minimum wage for essential support workers. Next slide. So with that, please also note that while draft rates are developed using inflation through January 2027, we still do not have an implementation timeframe because of various factors or actions required in order to implement changes. So sometimes these additional steps can limit implementation timelines or implementation in general. So along with the formal rate reform process that we are undertaking, there can be other steps required by the department in order to implement any rate recommendations. And so this can include things like budgetary asks or appropriations and approval from the Maine state legislature. It can be rulemaking by the department, so the rulemaking process in accordance with the Maine Administrative Procedure Act, or MAPA process, as some of you are familiar with. Can also require federal authority for changes, which can include approval of state plan amendments and 1915C home and community-based waiver amendments. And both of those require approval by the Centers for Medicare and Medicaid Services, or CMS. And another thing worth noting is just alongside those 1915C home and community-based waivers, those do require cost neutrality, which is a requirement basically, that means that the average cost of caring for a person in a home or community setting cannot exceed what the government would have spent if that same person were placed in an institution like a nursing home or a hospital. So keep in mind that some rates have not been updated in many years, and so those rates may have older models or have been implemented through legislative directives in the past. So it's not always clear how they were developed and when or how they or if they were considering things like the minimum wage changes that went into effect several years ago. So these draft rates do update the whole rate and all assumptions, not just wage-related data, and are based on a combination of data submitted to the department by participants and gathered from external sources. And final rates may change based on further review and consideration of any input received through the comment phase of this rate determination. And so we really appreciate everyone's time and input so far. And also, we're looking forward to additional input through the next phase of this project. And with that, I will pass it over to Jess to start our introductions.
Thank you, Kristen. Next slide, please. So who you have working on this project is a big team behind the scenes working with PCG. So myself, Jessica Levesque, I work for Delivery System Reform as a coordinator and leading this project. Heather Bengalis, who's acting LTSS policy manager, Megan Brooks, LTSS policy writer, Dwayne Parsons, who's the senior manager of reimbursement and fiscal management for MaineCare, Kristen, who she just introduced herself and kicked us off, Megan Scott, who is helping me run this meeting behind the scenes right now. She's the legislative and reform coordinator. Nicole Rooney, LTSS manager at ODES, and Derek Fales, associate director of developmental disabilities and brain injury services from ODES. So all of these people are behind the scenes and on the call today, most likely, and helping out. So that's your main team working on this project for you. I will hand it over to Kristen Gore, please. Next slide.
All right. Thanks, Jessica. So I'll introduce our PCG team. I'm Kristen Gore, Senior Consultant, Project Manager of this initiative. With me today, I have Rhonda Kern-Strauser. She's a Senior Advisor at PCG. Jeremy Thomas, a Senior Consultant. Erica Altman, a Business Analyst. And then not with us on the call, part of our project leadership includes Megan Morris, Joseph Carbo, and Luke Lofgren. All right, back to you, Jessica.
Okay, thank you. While I have this transition slide up, I just want to say that I'll be posting the housekeeping. In the interest of time, I'll be posting that in the chat. So some information to be looking for in the chat. So at a high level, I'm going to go over some rate reform process and review. Next slide, please. So the rate determination process is a main law that we have that's Title 22 MRS 3173-J, which was enacted in 2022. And at a high level, that law does the following things. It sets a regular schedule for rate review process and for us to adjust the rates. Number two, it ensures that there is a relevant state and national data to inform the rates. And so specifically for this study, what we've done is all the MaineCare services and rates were compared to their closest corresponding Medicare codes with a goal of aligning them with the reimbursement rates between two programs. We considered following key questions when we determined our benchmarks. Well, does the service description between MaineCare and Medicare align? Does the cost structure between MaineCare and Medicare align? So many MaineCare services and rates cannot be aligned closely with Medicare services due to the differences in their services description or the unit of measurement or other factors that we consider. So for those that did not align and we were not able to benchmark to Medicare, there's been a methodology and rate model developed on information that they're going to explain it a little bit on the following slides. And Number 3, it allows for formalizes our clear and transparent process for a rate determination, which is what today is. So thank you again for participating with us today, so that we can present to you what we've done for rates, and you can see clearly what we've done, and you can ask us questions, and then you have a period of time in which you will be able to ask, write some written comments into us. Fourth, it developed a MaineCare advisory committee specific for reform. And this committee, also known as the MAC, ensures the program remains effective, efficient, and responsive to the needs of the beneficiaries. And lastly, number 5, we have a technical advisory panel, also known as the TAP, and it advises on related technical matters as appropriate. Next slide, please. So specific to this rates determination, the following has happened. We sent the initiation notice in June 4th of 2024. We had a kickoff meeting in August of 2024. There was a period of interested party engagement meetings, which happened between September 4th, 24 and October 9th of 2024. And there was a period of time in which surveys were administered and people were able to fill this out and participate in that way. And that happened between October 22nd, 2024 and November 22nd, 2024. And that leads us to yesterday, today, and Monday, where we're presenting the draft rates and methodology specific to services and sections of policy. Such a large effort, as Kristen was saying, that we needed to split it into 3 separate meetings. You will, after this meeting, have the opportunity to write for your public comments, and they'll be due by July 13th. So that will be the same no matter what meeting you attend. All comments will be due July 13th. After we receive all those comments, what we'll do is consolidate them all, review them. We do review each and every comment submitted, consolidate alike comments, and then we do write a response to them, how or we were able to implement the feedback, or why we couldn't, or if it was in scope or not. And that is posted on our rate reform website once we have the written responses there. And then eventually there's rate finalization. But for today, we're here to talk about the draft rates presentation and talk about the public comment period. Next slide, please. Okay, so this is for anybody who's interested. We did hold yesterday's meeting. Today is today's meeting for clinical services and clinical therapy services. But for anybody who also needs to register and attend, Monday at 1:30, we'll be doing therapeutic interventions and assistive technology. Next slide, please. And at this point, I think I'm turning it over to Rhonda if she's able to come off mute.
Hi, Jessica. Can you hear me
Yay!
okay?
Yes.
I know. I apologize. I had to restart my computer. So my speakers will work. So hello, everybody. I'm Rhonda from PCG. I'm going to be talking about the rate setting methodology and those inputs. So next slide, please. So one of the first things I want to talk about is the independent draft rate model approach we utilized. This reflects the actual provider costs and the use of multiple data sources as displayed below in these large buckets, which we'll talk a little bit more about, to develop that final rate for each service. Certainly we utilize multiple data sources, leveraged, a variety of them to support the rate model inputs, such as staff wages, benefits, staffing levels, service settings, time to complete service, such as like documentation, and also those transportation costs. So in those large buckets, we started looking at the state policies, the rules and laws, which includes program policies, rules, and regulations from the MaineCare Benefit Manual, national resources like BLS data, wage data, and IRS mileage rates, and then the last 2, provider and interested party input, where we did a provider survey. We did interested party outreach. Some of you certainly may have participated in that. And then we also utilized alternative sources as well, such as Medicare benchmarking and peer state benchmarking as well. Next slide, please. So within that, let's talk a little bit more about this structure of each one of
All right, well, I'll chime in the meantime until she comes back. So the draft rate model structure covers all of the costs of the rate models to reflect the actual provider costs from multiple data sources. Each group was calculated by dividing the total costs by the number of participants. So what you can see here on the far left, primary basis of most of our models is always personnel costs. Personnel costs obviously take the bulk of it. Are you back?
I am back. I apologize. Apparently, my internet must be, it's cloudy here today. So when that happens in my area, it is not good. So I apologize. So the last thing there is the productivity adjustment. So the next thing we utilized is the non-personnel cost. So program support, overhead, and mileage included in that. And that gave us a total program cost. So once we got that, we took that total program cost and divided by the number of participants. One of the other things I want to identify is that the 10% incentive was added to all group services. Next slide, please. One of the next things we did, we benchmark rate variables, and let's talk about some of these. So direct staff service wage, that benchmarks variable because a variety of different people could be doing the service. So we utilized
All right, I'll step back in. So we utilized a number of services. So primarily the focus here is that we used foundationally the BLS wage data. This was from May 2024. Once we have that foundational wage data, you'll see that we use variable benchmarks, and we'll cover that a little more thoroughly here in a moment. But the fringe benefits were developed using a variable adjustment benefit and the payroll-related taxes. So you see that 946 plus 8.15%. Those are both combined to calculate the total fringe benefits for that position. We then add that non-billable baseline estimate of 25% in this example, travel time of 10% overall, with overhead costs at 15% and program support at 10%. So you'll start to see that, again, the foundational basis of the rate is the wage, and then we build around that on those additional components like the non-billable travel time, overhead costs, and program support. So when we add those all together, we also make sure that we have that mileage cost of 70 cents per mileage, and we'll see exactly how that works together here in a few minutes. I do want to make sure we mention that that overhead cost estimate of 15% is the CMS de minimis rate. So we wanted to make sure that all of our costs are aligned at every point with best practices, both federally and state. So really, we're seeing in here all of these percentages add up to that percentage. Next slide. All right, so let's see it in practice. So this is our rate model structure. This is just an example for you before we go into a little bit more detail later. But let's start at the very top again, looking at that hourly wage of $37.61. This one was based off of a May 24 BLS data. We would have a blend here, and so we've identified what that blend is, and then we want to make sure we add on those employee benefits. So that employee benefits would be that 946 plus 8 and 0.15% variable fixed benefits at 1252. Once you then take that, you were able to combine those into the total compensation of $50.14. I see Rhonda's back. I'm going to give her a chance. Are we stuck again? All right, I'll keep going. So what you see here, so you get that 14 percentage right there. And then what we need to do is add that billable, non-billable. So we've cost out a 1 hour of services based off of those wages. And then we need to make sure we're applying that 35% productivity adjustment for every 40 hours worked. 26 is direct billable time, 4 is for travel, and 10 is an additional non-billable percentage. But what that actually equals out to be is 1.54% of the total rate. So you're really getting an additional 54% to your rate for that cost factor. So when you add in that 54%, you end up back with 77.13 as the total direct staff cost per billable hour. We're still not done yet, so we want to make sure we're adding in those additional costs. So the program support costs at 10%, we're using a national benchmark of 10% for program costs. It's a best practice that we see in models all across the country. But that program support costs, make sure to cover all those additional things of people who are actually doing the work in action with those additional staff, generally support staff. And then we wanted to make sure we built in that 15% indirect cost per billable hour. And that indirect cost of 15% is based off of that CMS de minimis rate. And that's to pay for all of the back of house costs of HR, IT, all those additional fees. And then we make sure to add in the vehicle mileage costs. It is worth noting here that we have separated out the cost of the time above in that travel adjustment and the cost of the mileage below for that 507, right? So we're making sure to cover both bases within this rate. So it's fully comprehensive. Once you add those together, you end up with a total cost of 107.92 here, but that's not the rate, right? Because we want to do that for 15 minutes. So to create that 15 minutes, we take the total cost for the hour and then we just divide it in 4. So that gets us to our rate here of 26.98. All right, let's go to the next slide, please. So looking at here, one of the things we did was a full wage analysis. This wage analysis combined both survey data and our BLS adjusted data. So what you'll see here is each of the positions that we are using in the models today. So you'll see those from certified nursing assistant all the way down to the speech language pathologist. What we did when we did our survey is we reached out to all of you to ask, how much are you actually paying for these services? And in that process, we collected the data on that average reported for the provider survey data. Some had many more responses, some had fewer. So really being clear about what those were. We then compared that data to the Bureau of Labor Statistic using the median data figure. And when we looked at it, we noticed that the Bureau of Labor Statistics was generally higher than what we saw in the market. This is not rare. We see this kind of consistently across the board. Obviously, people are paying what they can. Also, time changes, inflation works. And so those Bureau of Labor Statistics figures can sometimes allow us to raise that benchmark up just a little bit. And so what you'll see here is the total wages used in model are the BLS figures, as they are generally higher and more robust than what we had seen reported. Next slide. So to build out these models, we assume that there are multiple people or position types that do this service that require different costs. So what we wanted to do was identify blends for each of the rates. We'll show you how they're used here in a few minutes, but we wanted to create blends for each of the rates to then be able to use a singular figure to create a singular rate, even though we recognize that these rates are covered by multiple. So for example, here in the therapy and therapy assistant blend, you will see that we're using 3 positions: occupational therapist, occupational therapy assistants, and physical therapists, each of which have some say in how the rate works. So we would say that 50% of this is built off of occupational therapists. So we'd assume that about 50% of the time an occupational therapist is doing this task. About 20% of the time it might be an OTA. And then a physical therapist might do it, assumed 30% of the time. So when we put these together, we do the weighted average to calculate an average hourly wage of $42.90 for our model. So this is how we build up each of those blends, and you'll be able to see the blends all listed in the appendix that we will go over here in a little bit. All right, next slide. Okay, so looking at those, we have, these are our, below are the wage assumptions for each position included in the draft rate models. So some of these have just one position, some of these have multiple, actually most of them have one. So nurse's aide, so nurse's assistant. We listed all of the Bureau of Labor Statistic codes, so you can go look for yourself if you wanted to. But we have all of those Bureau of Labor statistics, and then you'll see, I think I said only blend here is the healthcare social worker and rehabilitation counselors for the social worker counselor blend, and it's a 50-50 blend. Next slide. All right, so fringe benefits, we mentioned this a little bit before. So we have that fixed variable, which pays for specific components, and then we have that proportionate variable. The fixed variables in our model are paid leave, insurance, retirement, and savings, and you can see that all on the right with those inflation-adjusted amounts of 431, 354, and 160. Again, these are per hour, so we're making sure we're calculating these out. So the legally required benefits are the main payroll tax at $8.15 per 8% and 0.15. Sorry, excuse me. So the rates have been adjusted. So just making sure you know that while we aren't yet at 2027, we've made sure to inflate these to accommodate that fact. Next slide. All right, so speaking of inflation, we wanted to make sure we accounted for 12 months of inflationary data. So the rate implementation year of January 2027 applies a 2.68% to all current rate models per year. So the most recent 12-month inflationary data from Bureau of Labor Statistics shows us that 2.68%. Using that 2.68%, we will see that if we were to go into future years, the percentage that we are using right now would be increased by that proportion if that were to need to be applied. So you can see that raising from 8% all the way up to 17% if there were a delay in implementation, which we hope not. Next slide. All right, so I'm going to go over the draft rate recommendations. Again, you're going to hear me talk a little bit today. Sorry, we planned on to split it up, but I'll do my best. So draft rate recommendations, let's go to the next slide, please. All right, so what we're going to do is we're going to go over each of these draft rates one by one. I'm going to try, we have a lot of these, so I'm going to try to pace myself, but also move through these fairly quickly. The purpose of this organization of this is to show you how to find this information for yourself. So what we'll do is we'll go over all the rates and how they've changed, go over the comparisons, and then we'll move over to the appendix to show you exactly how you can trace all of our work from start to finish. So in these models, this is for the behavioral health assessment and reassessment. The 96156 codes, 58 and 59. Each of these have a fairly significant difference between each other, but it is worth noting that for this first section, all of these rates are being benchmarked to Medicare. So remembering that Medicare rates are required to be benchmarked if there is an applicable comparison. And so while these are going to be a little bit different, they're all being benchmarked to that same using the 72.4% rate, and I'll show you exactly how we do that. So, for example, for this first line, the behavioral health assessment was previously or currently $24.28 per visit for a max of 1 per day. So that rate has been significantly changed in Medicaid or Medicare and raised all the way up to the base for the 99. So this is all based off of Maine's locality of 105.16. So 105.16 is then adjusted to the 72.4% as written in statute. That is then create a 76.14 rate for that visit. So that's a change of 214%. So very, very significant. Now, these adjustments will happen differently. So you'll see that the middle, the behavioral health intervention face-to-face is much more modest, and then a slightly different change with behavioral health intervention face-to-face. Again, these are really the corrections to the Medicare rates, and so making sure we're really clear about that. Next slide. Continuing with the benchmarks, we have the health behavior intervention, face-to-face, the groups, and then the families. So with the groups, you'll see a consistent kind of downward trend. And then with the families, you'll see a split. These are based off of each specific code, and so there are quite a few factors that are included. But again, we're continuing to make sure that these benchmarks are correct and done effectively. Next slide. Continuing, we see that these benchmarks for therapeutic interventions that focus on cognitive function, so 97129, it benchmark rates at 2182. So really, again, down to 1580, which is a change from the 3061. Add-on code for each additional 15 minutes, also downturns about 51% from 30 to 20. Again, there's quite a bit going on in the Medicare rates with these changes overall. Next slide. All right, so looking at our self-care home management reintegration. So the 975 codes, we'll see here that they are all significantly increased. The current rate ranges in the $16 to $17 range. Again, the point to bring here is that these are all similarly based, and so you'll see that they have a similar Medicare locality rate. So that 3191 or the 3068, which are adjusted down to 2238 or 2221. All right, next slide, please. All right, so now we get into our clinical services. So this is for the models that were developed. So for these models that we developed, it's worth noting that these are all based off of a large array of historical models. So the current rates, some of which we have good knowledge of how they were previously made, some of them less knowledge, but the primary thing being here is consistency. So all of our models that we're going to discuss today use all of those same BLS factors, all of those blends, all of the same economic indicators, inflation rates. So all of those components together really level this out. So we'll see a little bit of changes. So here for the services of clinical social workers in a home health setting, we do see and build the rate to $26.98 as compared to the $43.31. We do see that with the health aid, it's a slightly different rate based off of the health aid's wages. And so you'll see that those wage comparisons create a smaller change overall. Next slide. So we're going through this. This is our first example here of our rates where we do the group scale. So you'll see here the very first of these, the G0156U7. The U7 is for a single person. So you'll see that is the foundational rate. All of the rates around this that you see below are based off of this foundational rate. And so you'll see that when you look at that rate compared to what the current rate is, we have 1696. It's compared to the current rate of 861. So that's an increase of 97%. When looking at each subsequent rate, just to give you that shorthand, it is divided by that number of members, and then you add a 10%. So 1696 divided by 2 plus 10% gets you 933. All the way down to the new rates, the home health aid, the home health services, that one is 1696 divided by 4 plus 10%. So really making sure that we're always identifying and providing that incentive for all. So what you'll notice if you multiply that 466 times 4, you will get higher than your original rate because we recognize that there are additional costs and effort going into those. Next slide. Continuing the same story, the G076 codes, those in the policy section 19, again, really trying to show you that consistency. The base rate of 6782 was developed as compared to the previous rate of 3434. Again, divided by 2 plus 10% for that 3730, 2487, and then 1865 for that final rate. Next slide. All right, so skilled nursing. Skilled nursing is based off of an RN wage. So this one has a singular position that we've built this off of. This one also has a fairly significant increase overall, with the current rate being 64.30 and increasing to 119.84. Again, this is all pretty repetitive, but we'll show you exactly how to look at the rates that you want to look at here in just a few moments. But you have that 65, 43, and 32 all scaling down based off of the division of that initial rate. Next slide. LPN, exactly same story. Again, I think it's really interesting to note which ones have significant increases. These are primarily based off of the wages and the changes to wages in recent years, and other factors. But really, there's quite a bit in these rates as well. So you have a base rate of 106 for an hour for one person. That is then divided by 2 plus 10% for that 58.32, and then the 38.88, and then the brand new rate for 4 at 29.16. Next slide. All right, so for skilled nursing, here we go. Skilled nursing is based off of RN in this context. So the draft rate for this, also noting that this is also a different time series than the previous. So this one is for a 15-minute unit. That 15-minute unit is 29.96 as compared to that 39.36. But then you see the 15-minute for the RN non-Medicare certified home health agency is also 29.96, but compared to the current rate of 16.48. So this is another great spot where MaineCare is working to consistently make the rates more consistent and make the methodology as universal as possible to be highly defendable. So continuing on, we have that skilled nursing RN Medicare certified home health agency, 2 members served at 16.48, 3 members served at 10.99, and then 4 members served at 8.24. So again, continuing that same structure for every rate so that they are consistent and defendable. Next slide. All right, continuing this on. So straight RN services under the G299 code frame. We have 15-minute unit at 29.96, looks familiar, at 16.48 for 2, 10.99 for 3, and 8.24 for 4. Again, consistency is key here. Next slide. All right, nursing visits. So for LPN, we have a slightly different rate here for this one because it's a slightly different system. And so for the LPN, we have a draft rate of 26.51 for 15 minutes. Mild change from the previous rate of 27.56. But when you get into the non-certified home health agency, you get the 26.51, which is a significant increase. And then again, for 2 members served, 14.58, for 3 members served, 9.72, and for 4 members served, 7.29. Same math across the board. Next slide. Thank you for your patience. I'm trying to make this as entertaining as possible. Okay, continuing. LPN services, G0300. LPN services at 15 minutes is 26.51. For 2, 14.58. For 3, 9.72, and for 4, 7.29. All of the base foundations you'll start to be able to trace and start to notice how clustered these are, because again, it's just the slight changes in the wage models that make the primary difference between these. Next slide. CNA, Home Health Services for 15 minutes, has a draft rate of 19.25. The CNA Home Health Services with 2 members served is 10.59. 3 members is 7.06, and the brand new rate of 4 members is 5.29, all of which are significantly increasing. All right, home health aid CNA services comes in at 19.25. The home health aid with 2, 10.59, 7.06, and 5.29. Again, consistency is key, same as the last slide. Next. RN has quite a bit of an increase, obviously, because of the amazing work that they do. So looking at that draft rate of $29.96 for a single patient, $16.48 for 2 patients, $10.99 for 3 patients, and then that new rate of 4+, $8.24. All right, consultations. Consultation psychologist or psychological has a draft rate of $34.21 for 15 minutes, which is consistent amongst both versions of the rate and 44% increase over the current. All right, Medical social service visits, home health services. This is a nice little blend. So this also shows you the difference between the 15-minute rate calculation and the per visit calculation and that significant difference. So really the draft rate of $26.98 is quite a big jump. $107.92 per visit, $23.16 and $23.16. So you'll see that they're different percentages, again, trying to make some more consistency between the various rate components. Next slide. All right, so while we were going through those, we got a couple that were decreased. So we wanted to discuss exactly what the decrease was. So looking at these, this is the services for a clinical social worker in a home health setting, services of a home health aide in a home health setting, both of which had decreases. The rate decreases foreseen for these were because of a couple of different things. Primarily for similar services across policy sections, the rate model used consistent or similar wages in the rate model to ensure consistency. So when we're using those consistencies, historically, some of these rates might have been much higher based off of previous assumptions or previous expectations. And so in making those consistent and putting a through line with them, some of them have to drop down to make sure that they're operating in function. And then this initiative to ensure consistency of rate methodology and equity led to a decrease in some sections with the same services in another policy section. So really it's also thinking between the policy sections and the actual roles themselves. Next slide. All right, so these G299 and G0300, same story. Really just making the consistency of expectations for an RN. We're using the same RN wages. We're using the same RN fringe benefits. We're using all the same unbillable percentages. So that's going to cause a little bit of rebalancing. Next slide. But most of the decreases today were found in the Medicare rate benchmarks. Again, we used the most recent Medicare benchmarks. We reviewed all of the Medicare rates as compared to the rate expectations and continued to make sure that these are all aligned effectively. We have seen some changes to Medicare rates in the last few years. So that could also be here, but it could also just be benchmarking and making sure that they're all most appropriate. Next slide. Oh, no, not next slide. All right, I'm going to take you through how to review this on your own.
And while Jeremy pulls up that appendix to show folks how to identify and go through each of the rate models that PCG developed, I just want to call out that within this appendix, you will not find models for rates that have been benchmarked to Medicare because obviously those are not models. Those are benchmarked to a Medicare source. So just in anticipation of questions from folks in attendance or that might review these models after the fact, you will not find Medicare benchmark services in the appendix. Those details are within the presentation only.
Yeah. So to give you an example, we don't have anything to share because we pulled down a list of rates and then 72.4 and then that is the rate. So there wasn't a whole lot to share. So in this appendix, MaineCare and the PCG team really wanted to make sure that you had every ability to go look at all the details possible in the easiest and most accessible format. So this appendix is that. So what you'll see here is there's going to be 3 different appendices if you cover different services. So this is the one for all of the services today. So for all the clinical rates, and so you'll see a quick brief explanation, and then it just dives straight into each individual model. I will note before I go through these that down at the very bottom, sorry, scroll, we have our position wages and blends. So if you wanted to, you could go and you could look up the certified nursing aid assistant wage and make sure we're doing it correctly. We are, but make sure that you see how that's all done, but you can see what the blends are. We don't have particularly interesting blends, I think, in this presentation. I think this 50/50 is the biggest, but overall, making sure that you understand why we've selected those is the purpose here. But so for each individual model, like we covered before, let's go all the way back up to the top. Let's pick a non-group one. All right, so for the services of a clinical social worker in a home health setting, each model as developed is listed. I'm not going to go through this detail by detail, but you can follow the math and see how we started with a direct service wage of $37.61. We added those employee benefits to get a total cost per hour per person during doing the work of $50.14. We then assumed that about 54% of your time is going to be spent traveling or doing other things to make sure that hour works. So we add that in to make a total hour cost for that person of $77.13 per hour. We then use those flat percentages based on national best practices and CMS data to give you an additional $10.28 and a $15.43 to cover all those other costs outside of that person. And then again, splitting out the travel time for that person above and the cost for the actual vehicle mileage down below, making sure that they're fully covered and you can see all of those costs. Combine that all up to say that for 1 hour, we're saying that this person would need to cost about $107.92, but they're going to do a 15-minute service. So we're actually going to pay $26.98 for that 15-minute service. So as we continue this work, so every single model that we developed is listed in this appendix. Again, not the benchmarks, but the others. But I do just want to share the one little spot where you can see the group rate, just so you can check it out. So essentially, it's the exact same process. We started with that 1954, built all the way up to 47 for an hour. And then you add it all together. It costs 67 for an hour, but you're going to do a 15-minute session. That 15-minute session is $16.96, but you're going to do it for 4. So you're actually going to get $4.66 per person, but that'll actually be more than that $16.96 when you actually equate it all out. So again, all of these models are listed. They do note at the top of each model what procedure code, modifier, revenue code, and section of policy. And then they also make sure to show you what blend or non-blend we're using in this case, and the unit. So again, the point being here is that you all can go in and look and provide very specific feedback because we would love to see that. I'm going to pass it back to, I think, Kristen.
Thanks, Jeremy. I think we have it up on the screen here. And then Jessica, you're going to walk us through our next steps.
Okay. Thank you, Kristen. Thanks, Jeremy, for all of that information and stepping in. So next steps, I'm just going to say before I go into this, if you're thinking about after this, we're going to do comments and questions. And if you have a specific model or code in mind that you would like to see during the question session, please feel free to ask and we'll put that up specifically for you. So here we are, next steps in the project. Now in this project, we will post, what does this say? Draft model recommendations will be posted on June 29th for public review. That means everything from today's session will be posted on our rate reform site, and there will be a notice that will go out providing links of how to access this. So I'm just going to say for anybody who attended yesterday's presentation, You may be experiencing a few glitches when you're going out to the website. We are working on that. Thank you for your patience. We are aware of it and we are working on that. So things might not be available till Monday, but please keep checking or letting me know if it's been past Monday and you can't access yesterday's and today's information, because we do hope to have it all posted and corrected by the end of the day, Monday. Comment period is open now, today. If you would like to give official comments next when we take comments, we're happy to take them verbally. Also, you can submit them in writing between today and July 13th, as I stated earlier, and you can submit those to the email that we provided there. I'm going to be posting this information in the chat in a second too, so you can have this to copy and paste real quick from the chat. As I had stated earlier, we'll take those comments and consolidate them, and then we post the responses on this website, which I'm going to post the link to that again. And then when we get those, what we consider is whether it's appropriate to make any changes to the draft rates that we've presented today. Please remember, we do want your participation. I know we've said it multiple times throughout the presentation, but we really do want you to give us your feedback on these draft models so we can understand from your perspective, how that feels, what it looks like. So send us your feedback, and ultimately we'll see whether they end up the same, higher, or whatever. So next slide, please. So before we get into the Q&A section, I just want to make sure everybody's aware of how to participate. If you would like to ask a question or state a comment, of course, the Q&A is open. So if somebody feels more comfortable typing it into the Q&A box, we can read that for you and then answer or take it back. But for somebody who would like to raise your hand, please do so with the reactions at the bottom of your screen. And so I'm asking you to raise your virtual hand. We would call on you in the order that the hands are raised. And when you do come off of mute, please introduce yourself and the organization that you represent. And because we have a pretty good group on today and a half an hour for questions and comments, we want to save time for everyone. If you can limit to 3 minutes, you're allowed to come back on though, ask another question. That's totally fine. I do know we do have 1 or 2 people on the phone. So if someone participating on the phone would like to raise their virtual hand for me, it would press *9 on your keypad and I'll be able to call on you. So with that said, I know you might be looking up your codes, so we can pull those up for you specifically. That'd be great. Who would like to kick us off? Usually just takes somebody to raise their hand first and ask a question. That's what we're here for today. I know we went over a lot, and so it might be you have to review the information, and that's understandable. And we are available through that email that we posted. My email's usually available in lots of spots for people to be able to email me with a question later after this meeting. So I don't want you to think like now's the only time, but now's a great time because it's we can give you an answer or review in real time. And we are having some glitches with posting some things, so you might not be able to see stuff until Monday. I guess while we wait to see if people raise your hand, I just wanted to say that when I know it was a question we had from yesterday's meeting, but the BLS data that Jeremy shared is specific to the state of Maine. So if anybody was curious about that, it's not national data, it's not regional data, it's Maine specific. Jeremy, can you believe you maybe aren't going to present any specific codes today?
I'm excited to. So if you wanna look at one of the specific models, let me know. I can talk about these all day.
Right. You will have access to them, like we said, after this meeting, but Jeremy put them together so we can put them, right there. Like, look at this one, Jeremy. Okay, I'm gonna give another minute. I just want to say that throughout the meeting, I have posted some things in the chat. For people who, I know you're on this call, so you probably already got notices, but if not, I always like to post the link and put a plug in for signing up for notices. So it's important to us that we have great participation. So anybody who maybe got this meeting forwarded to them and would like to sign up for future notices, that's how you keep up to date, not just on this project, but others, and how you register, how you would get the information after the meetings, when we post responses, all of that. We've also posted the Rate Reform Systems website in the chat. I've posted the email link in the chat, and also a reminder of we're accepting comments as of yesterday through July 13th for anybody who's interested. And I'm not seeing any questions in the Q&A. And I'd like somebody else on my team to check that because yesterday I was not seeing the.
I'm not
Right.
seeing any Q&A
Okay.
in the Q&A, Jess. I guess since we're not getting any questions, I hope that's a good sign. That the information provided was easily digestible and we were just clear on everything. But in the event that you do have questions after the fact or once you review the materials, as Jess mentioned, email address is available. Please use it. And then I'll just put an additional plug-in for the fact that we do have a third presentation scheduled for next week, be Monday, for the remaining services in this study, the therapeutic intervention and assistive technology services. So if you or someone you know are interested in those services, please sign up in advance or distribute that information as you see fit in order to get others to sign up. And I think we could probably just give it a couple more minutes, Jess, to see if anybody has any questions. And if not, then we could conclude.
Sure. How about we stay on till 11:05, unless the questions start coming in, and we're here till 11:30. I'm not seeing. Yeah, I will take it as a good sign also. And I was trying to think of it, if there were any questions asked yesterday that maybe would be pertain to today or would be helpful. That we didn't go over. No. Okay. All right, 2 more minutes. All right. Okay, well, we're down to seconds now. So if anybody has anything, oh, and please follow up in an email or anything later if you think of something or once you've had a time to do it or, review the materials, that'll be great. And we are doing our best to get that information posted for you and for the notice to go out. The notice probably will not go out until Monday. Part of the confusion yesterday was the notice went out and the material was not posted on the website yet. But we are working on getting that information up there. Okay.
So I
Perfect.
guess just in conclusion, just really want to thank everybody, for their time today, and we're really looking forward to your input through the next phase of this. Again, I know Jess has provided the comment deadline many times now, but the 13th, and so we look forward to hearing from you.
Thank you, everyone. Have a great day.